Hi, everyone. I'm Dr. Janina Jeff, staff bioinformatics scientist here at Illumina. And today, I have the opportunity of speaking with Kristine Ashcraft from Invitae. Hi, Kristine.
Hi. Thanks so much for having me. I am the Medical Affairs Director for Pharmacogenomics at Invitae. Have been in the field a little over 20 years and am incredibly excited about the progress and to be here today. So thank you.
Yes, thanks for joining. So the field of PGX, it has come a long way. Tell me a little bit about your work in pharmacogenomics at Invitae.
Sure. So Invitae acquired the laboratory that I worked at starting in 2000. Actually was one of the first CLIA-accredited labs to offer pharmacogenomic testing in the country. Wow. So I've had a, I think, pretty unique ability to watch it progress over the last 22 years. When we first started, we were doing single gene tests for 2D6, 2C9, 2C19, and now we have a robust 38 gene panel that costs a fraction of what it cost to do a single gene back in the day.
Wow.
And also have the ability to provide real-time drug and dose optimization guidance right in the EHR based on that information. So very excited about the progress that's been made.
Here we have a field where a lot of the variants are pretty common and actionable, which is very unique. So talk a little bit about how the field of pharmacogenomics has evolved over the last 20 years or so.
Yeah, well, I will agree with you. Actually started that journey in 2000 because there was an article in Fortune magazine about a little boy named Michael who died of an overdose because he had an easily testable cytochrome variation that in concert with his other medications led to deadly levels of Prozac in his system. And the article talked about the dawning of the age of precision medicine, when we would use genetic information to be certain we were giving patients the safest drugs and doses that the evidence allowed for. So what do good molecular biology geeks do? Yeah. They go to PubMed, right? Yeah. I was like, just how common are these variations? Just how many drugs do they impact? And even back in 2000, there were already literally thousands upon thousands of publications on just how important these variations are and how many drugs they impact. And naively thought, well, this will be standard of care in 5-6 years tops.
But this was in 2000.
This is in 2000.
Okay, I love your ambition.
Very optimistic. But what we ran into, and I think this is the same thing that we run into in genetics everywhere for clinical genomics, I spoke with a lot of patients, payers, providers, and the common thread of questions was, well, how do I know which patients to test? Mm-hmm. How do I know how to act on that in the context of other things that impact drug response or disease treatment or what have you? It's not just the genetic component.
Yeah.
Where are the studies validating that this actually improves outcomes and reduces healthcare costs? So I believe we've done a really good job of answering all of those questions. Very lucky that we stumbled across a software program early on that was originally created by a couple of frustrated psychiatrists that ran into cytochrome P450 interactions in their practice that existing tools did a really poor job of warning them about. And so they actually curated the literature to look at the biological basis for interactions. And because of the way they had designed this, we were able to upgrade the software to take pharmacogenetics into account, because it's a very similar mechanism of action. And when we started offering this tool to referrers, they said, of course, hey, that's awesome, love this tool, best clinical decision support tool I've seen for medication management, but if you don't put it in the clinical workflow in my electronic health record, I'm not going to use it very often.
Yeah.
So in 2016, I was able to spin that clinical decision support tool out of the lab. We had the tool embedded in Epic and Cerner, and we're not the only tool.
So what is the name of the tool?
UScript.
UScript, okay. And what does it do?
So I think that the easiest way to describe it without getting too technical, what we've done historically is manage medications with the equivalent of a paper map. We pretend everyone has the same highway system, which are the liver enzymes that we're essentially testing our genetic ability to create. So most of the time when we take a medication, we take it in an active form, and it's processed by these liver enzymes, think of them like highways, right? To be converted to something our body can flush out and get rid of. So we're pretending everybody has 2 lanes of these genetic highway, same paper map, right? What we do with UScript is essentially the same jump we took when we moved from paper maps to the real-time traffic app on our phone.
Okay.
Only instead of warning of traffic jams and road closures, we're warning of metabolic traffic jams.
Yeah.
Whether the cause is drugs, genes, herbals, foods like grapefruit juice. And just like that app on your phone is like, I-5 is shut down today, here's how to get to work instead. We're like, 2D6 is shut down. Here's an antidepressant that does the same thing.
Okay.
That will help you get where you need to go with this patient. And we can do that in real time, right in the electronic health record.
So I have to tell you, this highway analogy is great. I mean, I create analogies all the time when I do genetics education. So thank you for that. I was very, very clear. Now, in this work, you've been in the field for over 20 years now. You've seen a lot of different technologies, sequencing, genotyping, TACMan assays. You've seen them all, I'm sure.
Yeah, well, I think one of the things I'm most excited about is we're finally to a place where sequencing can do 2D6. There's a pseudogene here. It's always been kind of complicated. And they're finally, when I was at the CPIC conference, finally being able to dial it in, which I think is kind of the dream, right? Let's do sequencing once, store this information, and interrogate it to provide everything we need to help optimize healthcare and prevent harm, right? So not only can we get the proactive genetic screening to see if you have any cancer, cardiomyopathies, genetic risks, but also all of the pharmacogenetic information. And we had to be a lot more targeted in the type of testing we did in the past in order to properly do 2D6. But I'm excited, especially with the cost reductions now, that it seems that all of that is starting to merge.
It's super exciting, especially now.
Yeah, so part of that genome information, as I said, is going to include pharmacogenetics. So if we have a low-cost way to look at disease risk and proactively manage it, as well as medication risk. I know that a lot of the focus historically has been on oncology and rare disease, but I may be biased. I think pharmacogenomics is the wedge case to make providers aware of genetics and the impact it can have. Greater than 99% of patients have a pharmacogenetic variation.
Wow.
That will cause them to have an atypical response to medications, and virtually everyone will take a medication in their life, if not everyone. Not everyone will get cancer, thankfully. Not everyone has a rare disease, thankfully. But everyone will have to have a prescription, and without this information, they could be given something that could harm them, and certainly something that couldn't work.
Now, that is I need to take everything you just said and tell it to a lot of our customers so they can see. But we do see a shift in a lot of customers seeing the value of genomics, especially in these large biobanks. And that's something where I feel like pharmacogenomics has really done well, being able to work with these large biobanks and using pharmacogenomics as a tool to introduce genomics into the healthcare networks. So I completely agree with you. So talk to me a little bit about some partnerships you have going with Invitae.
Yeah, definitely. So the Morehouse Cares program is amazing, and I would say very visionary. They're going after 3 key pillars we need to address to really improve equity and access in genomics. So there's an educational component. So Morehouse is increasing educational programs. I don't remember the stat that James Lillard had yesterday, but there are very few genetic counselors in the United States, less than 100, that are of African ancestry.
Yeah.
And so they are creating more educational programs through Morehouse for genetic counselors, bioinformaticists, and improving their genomics education. So that's on the education side. Then there's the clinical piece, making sure in their total cancer care program that everybody that would benefit from genetic sequencing gets access to that, hereditary cancer testing, et cetera. So they're doing that. And importantly, the patients are given the opportunity to be part of Invitae's Citizen platform, Citizen with 2 I's. And this is a platform that enables the patient to get all of their medical data from all of these disparate different medical records and EHRs. We know about our interoperability issues, and also have their genetic information in that. But it is up to the patient whether they want to share that information or not, and with who. And if there are any research opportunities and there's any revenue, they get to share in that. So they get the benefit of both the information as well as if there are research opportunities they're linked to that can maybe help their care, but also also if there's any financial incentive, they get to share in that. So there's both the clinical, the research, and the education. And I think it's a great program. And they're going to work to replicate it with partners in the communities.
For the last pillar of kind of this community engagement involvement, is this going to be an opportunity where you can centralize all your health records from different health systems?
Yeah.
Okay.
And what's amazing about that, there was actually a press release the other day. The Citizen Project had the first approval of a drug that used complete real-world evidence from the Citizen platform. So it's, I think, amazing application of both genetic information as well as patient-provided information.
Yeah. Okay. Well, this sounds really exciting. So thank you so much for joining me here in the Lightbox. I'm looking forward to our talk later.
Thanks for having me.